And so what I'm going to take you through in the next hour is really how we've evolved in congenital heart disease and how the outcomes of patients with congenital heart disease has really improved over time. And it's actually quite outstanding. So I'm going to take you through this. So this is a slide from 2014, still very relevant today. You can see on the left-hand side that it is there's a bar chart. It's looking at all patients with congenital heart disease. And so you can see that the adults are in red and the children are in purple. And you can see that over time, the amount of children with congenital heart disease has remained the same. But, see my cursor up there? Yeah. But the number of adults with congenital heart disease has been exponentially increasing. And that is the same as with complex congenital heart disease, which is a subset, which I'll go into what exactly complex is. But you can see that the number of children with complex congenital heart disease has remained the same over time, whereas the adults, as in the children growing into adults and living well into adulthood, is increased over time. And this is why this area of adult congenital heart disease is an expanding specialty, certainly increasing number of physicians, nurses, allied health staff to cater for this growing population. And so, as I said, there is different classifications of congenital heart disease. And so this is from the ESC guidelines from not long ago, and the ACC is slightly different, but very much the same. I've just used this to show the example that there's mild congenital heart disease, moderate and severe or complex congenital heart disease. And so if we're talking about mild congenital heart disease, these are the small shunts, so small ASDs, VSDs, PDAs. Even if they're unrepaired, these patients tend to do very well. If they're repaired, so if they were larger and they got repaired and they had no sequelae, these patients do very well as well. Both the patients that are considered mild congenital heart disease have normal exercise tolerance, normal life expectancy, and really unremarkable medical courses with regards to their cardiac disease. In terms of moderate congenital heart disease, tetralogy of Fallot probably is on the more severe end of the moderate spectrum. And then and it really varies. So tetralogy of Fallot, a large proportion of them will do extremely well and will fall into that moderate range. But there is a small subset that will present more severely, require more operations, have more arrhythmias. Small proportion may need transplant. Ebstein's anomaly, transposition of the great arteries who have had an arterial switch. So that's the modern day surgery for this type of congenital anomaly. It was introduced in the 1990s, and now any child born with transposition would have that kind of repair. And if they have that kind of repair, they should do extremely well. And in general, will have normal exercise tolerance and life expectancy as well. Atrioventricular septal defects, coarctation of the aorta, pulmonary stenosis, subvalvular, supravalvular AS. So they kind of all fall into the moderate range, and a lot of the patients in the moderate range will actually do very well throughout life and have near normal life expectancy. It's the patients in this severe or complex classification that is certainly the ones that we tend to worry about more. Cyanotic heart disease, whether it be repaired or unrepaired, univentricular physiology. So if it's repaired, they would have had a Fontan procedure, or unrepaired, they would be cyanotic. And transposition of the great arteries, if they had the older type of surgery, so like Mustard, settings, etc., they'd have a systemic right ventricle and they would be considered complex congenital heart disease. I'm going to go into these a little bit more. So, I think medicine has evolved considerably in general, and cardiology is in particular is much the same. This slide just basically has a whole host of, devices, etc., that have evolved over time. You've got your transcatheter aortic valve, mitral valves, tricuspid valves. Then you've got changes in how pacemakers have evolved over time. Pharmacological therapy within cardiology has evolved, heart failure therapy, pulmonary hypertension therapy. So, we always talk about all these other aspects, and a lot of this actually is very useful, and we use a lot of these aspects in management of congenital heart disease. But I think the evolution of congenital heart disease is not understood, but as I say, it is quite remarkable. And so I pose this as a trivia question. I think it's a bit of a tricky question, but who first described congenital heart disease and what did they describe? I'm going to give it like a 5-second wait. Does anyone know? Because I certainly didn't myself, and it's a bit of a tricky question. But it was basically Leonardo da Vinci in the 1500s. He actually drew an anatomical depiction of anomalous pulmonary venous return. So the pulmonary veins were not coming to the left atrium, they were going somewhere else. I find this quite interesting because it's actually one of those things now with CT scans, etc. We can easily pick these up, but back in the day it would have been hard, and I suspect it would have been post-mortem that this would have been identified, but he anatomically drew it. So the understanding there was congenital heart disease, it's been around a long time, but it wasn't until 1930s when there was a real interest in trying to make a difference for these children. And so Dr. Helen Taussig was an American physician. She was dyslexic. She, however, excelled educationally, academically, and thrived in cardiac research. She trained at Harvard, went over to Johns Hopkins in the latter part of her training to do more cardiac research. And then she subsequently started working there. And she actually lost her hearing at the end by the time she had graduated. And so she was using hearing aids. And you can imagine how challenging that would have been in a time where examination is key for these, for physicians back then. I'm not saying it's not anymore. We all still use our stethoscopes, but it really was key. And so she was really doing work that was very challenging. In 1930, she was appointed the head of Children's Heart Clinic at Johns Hopkins, and she basically worked there till retirement. But what her interest became in was looking after these blue babies. And at that time, it was called fatal blue baby syndrome because any baby that was born cyanotic essentially died within a few days. So what she would do was she would do a careful history exam, blood pressure, 3-lead ECG, fluoroscopy, and chest x-ray. That's what they had. And then what happened was after the babies died, sadly, she would look at the post-mortem and then try to fit things together, and she'd eventually come up to a reasonable, functional, accurate diagnosis. And so she started to really have a good understanding of what congenital anatomical defects were. So while she was working at that in Johns Hopkins, Dr. Robert Gross, late 1930s, he actually ended up performing the first cardiac surgery. And so he was not at Johns Hopkins, he was at Brigham, and he was basically a cardiac surgeon, and he was actually a chief surgical resident, working under his mentor, Dr. William Ladd, another famous surgeon. And he was presented with the 7-year-old girl that you can see in the corner there, and her name was Lorraine Sweeney. She was the youngest of 8 children, and she was just not thriving. Her parents were saying she was continually weak, she couldn't do anything, and they could hear a buzzing noise in her chest. Everyone suspected she had congenital heart disease. 1, they couldn't quite confirm it, but 2, there was no treatment available anyway back at this time. And so Lorraine's mother brought her to Boston Children's, he was working at Boston Children's Hospital, and they met Dr. Gross, and they asked him if there was anything that he could do. He immediately figured out it was a PDA. So it was a patent ductus arteriosus. So small shunt from the aorta to the pulmonary artery. I shouldn't say small, it must have been large for her, but so as I said, small PDAs, they can be asymptomatic. They wouldn't cause too many problems, but it's the large PDAs that can cause heart failure, growth restriction, failure to thrive, and this continuous murmur. And obviously, if unrepaired, it leads to pulmonary hypertension because of all that aortic to pulmonary flow. And when the pulmonary pressures are greater than the systemic, it becomes Eisenmenger syndrome. And back in the 1930s, by about the age 20, at least, these patients were dying if they had developed pulmonary hypertension or Eisenmenger. So he had picked up that it was a patent ductus arteriosus, and he was keen to try to operate on it. It had actually been the case that this gentleman, Dr. Strider, just 1 year prior, had actually tried to close a PDA. He had tried to close it in a 22-year-old who had endocarditis. So the young woman had Streptococcus viridans endocarditis at the time. And so he was presented her in a very urgent situation, and there were really no options for this young woman. So he went in, he tried to tie it off, but unfortunately there was so much inflammation because of the endocarditis, he couldn't. And then he ended up putting some sutures in and closing it off, not completely, not completely because he couldn't. So he put as many sutures as he could. And the operation was successful, but the patient had a cardiac arrest and died 4 days postoperatively. And what they found at autopsy was small necrotic pulmonary infarcts. They saw the vegetations, etc., and they saw a tiny little PDA lumen. And I think, as I was saying, by the time they get to 20-ish years old, if they've had a significant sized PDA, they've developed pulmonary hypertension. And we know that it's contraindicated to close these defects. And the patient probably had RV failure and arrested, amongst all the other things, including the fact she had, unfortunately, endocarditis as well. So while he tried it, it had been a successful procedure. The patient didn't survive. So, so Dr. Gross really wanted to do this operation. His mentor was against it. His mentor went on holidays for a few weeks. And during those few weeks, Dr. Gross went ahead and just did it. And so he did, in 1938, he performed a surgical PDA ligation. He tried to resect the PDA, but he couldn't because it was too short. So he ended up tying it up, and it was successful. And this girl, Lorraine Sweeney, that's a picture of her at the age of 73. So once she'd had it closed, she lived a pretty long and uneventful life from her cardiac disease anyway. And it was the first successful surgery in terms of congenital heart disease. So, as I say, PDA, people used to die from PDAs in the 1930s. Now we consider it mild congenital heart disease, especially when you repair it early on and there's no sequelae of the condition. And now we don't even sometimes have to do surgery. We have devices that can occlude the duct, even in babies. And so really surgery is not always needed as well these days. So Dr. Taussig, who'd been looking at these blue babies, heard about Dr. Gross doing this surgery, and she asked him, she said, look, you've just closed a duct. These babies are dying. Is there a way to increase blood flow to the lungs? So he's basically ligated a duct that was going to the pulmonary artery. She asked him, can you create a duct that goes to the pulmonary artery and provides more blood flow? He was very reluctant to pursue this. Maybe he'd had his one moment of glory. Maybe he didn't want to do any more, out of the book surgery. And so he was really reluctant to do this. But then these two newcomers came along. Sorry, it's getting cut out at the bottom there, but this was on the left, Dr. Alfred Blaylock and Vivian Thomas on the right. And they had just arrived at Johns Hopkins 2 years prior in 1941. And they have a remarkable story together, actually. Vivian Thomas, the gentleman on the right, he was actually 18 years old in the 1930s. He was a carpentry assistant, and he had plans to go to medical school. And he was working to earn money to go to medical school, but the Depression hit and he didn't get enough money, save up enough money to go. And so that year he went to Dr. Blaylock. It was a hospital in Tennessee, and he said, can I become your lab assistant? And it was an unlikely pair. And really that was the era of where African Americans really weren't physicians, lab technicians, etc. They were generally janitors in the hospital. So this was a big ask. But Dr. Blaylock saw potential in him, and he was absolutely correct. And so these two actually teamed up over 30 years doing pioneering surgical work. And I'll tell you what they did with regards to Dr. Taussig's question. And so this is a picture of Vivian Thomas in the lab. He would be in the lab for days. He would stay in the lab after hours. He would work trying to figure out solutions to problems. Every year, he tried to get back into medical school, but every year he realized this really wasn't going to happen. The Depression hit. He actually did not have funding. And every year he realized that was just a dream. So he stayed on with Dr. Blaylock. And the two of them together worked for many years, and they actually became like a package deal. So Dr. Blaylock would get offered jobs at different places, but he would not go anywhere that would not hire Vivian. He got offered a job at Henry Ford, but they were not accepting African-American employees at that time. And so Dr. Blaylock turned that job down. But then when he got offered a job at Johns Hopkins, Vivian was given the opportunity to join him. And that's how they both ended up at Johns Hopkins. And so in 1943, Dr. Taussig approaches them, and Vivian Thomas goes into the lab. He tries to create this cyanotic defect in dogs. And his questions were, how are we going to get rid of the cyanosis, and how are we going to make the dogs or the babies survive it? And while he was working on this, one day, there was a cyanotic baby that arrived in the hospital, Eileen Saxon. She was 15 months old, and she was in an oxygen tent at Johns Hopkins Hospital. And what she had was tetralogy of Fallot. And so you can see there, and just to go over it again, tetralogy of Fallot is basically an overriding aorta. You've got a large VSD there. You've got the pulmonary valve is narrow. It's usually subvalvular. So it's usually just below the level of the valve obstruction, but there can be narrowing at the level of the valve, and then right ventricular hypertrophy. And so the baby was cyanotic, wasn't getting enough blood flow to the lungs. And so they basically had to try this out on her because there really wasn't any options for her. And so in November 1944, Dr. Blaylock did this first ever surgery. And this is how the operating room looked. And this was Vivian Thomas. Vivian wasn't going to go into the OR because he was not a physician, but Dr. Blaylock insisted he stand right behind him while he did this surgery, because Vivian had done the procedure in several dogs, but Dr. Blaylock had only done it in one before this, doing it in this young girl. And what they created, you can see, is now what's called a Blaylock Taussig shunt. They basically got the subclavian artery and they redirected it and attached to the left pulmonary artery. So they've created a systemic to pulmonary artery shunt, thereby giving pulmonary blood flow. It will be bidirectional, so it'll go to the left and the right lung. And so it kind of bypasses the obstruction that was at that pulmonary and subpulmonary level. And so this was a temporizing measure, and they did this, and the effects of this operation were dramatic, and it was like a miracle. And before you knew it, everyone had heard about it. This operating room became the heart room, and people were bringing cyanotic babies from all over the world, all over the United States, to get them to have this surgery. And so they were doing several of these procedures day in and day out. And so Vivian Thomas never did go to medical school, but about 30-something years later, he did get an honorary doctorate for all his work, because this was just one of the many things that they had achieved. And he was appointed to the medical school faculty. And now there is a Vivian Thomas Fund, actually in memory of him, but also to help others with economic and racial barriers to try to achieve success in a much more straightforward way than he probably did at that time. And so this partnership, there's several books about it, and there's actually a movie about it called Something the Lord Made. And if any of you have time, I would recommend you watch it. It's a great film. It's a film about perseverance in a time where there was a lot of challenges up against Vivian and probably against Dr. Blaylock as well. And just this great partnership that really changed the way we do congenital heart disease. So this is a gentleman, his name's cut off at the bottom. His name's Hugh Edenburn, and he was blue baby number 44. So every cyanotic baby that got this procedure was given a number, and this is him when he's 76, so he did pretty well. He had a BT, and I've called it BTT shunt because it really should be the Blaylock Thomas Taussig shunt. He had it when he was two and a half years old. At that time, they quoted an operative mortality of about 14% for these procedures. Now it's less than 5%. And he obviously lived to a very old age. But as I said, that shunt's really palliative. I'm sorry, this slide just didn't work for me. But this slide was meant to show you that about 10 years after that BT shunt was created, two surgeons actually wrote up a case report series of 10 patients who had intracardiac repair. And so basically intracardiac repair is the complete repair for tetralogy of Fallot. It means closing that VSD up and relieving that pulmonary or subpulmonary obstruction. And so he had that when he was 18 years old, and he went on to live until he was at least 76. And so, as you can see here, tetralogy fellow falls into that moderate complexity, and it can vary. People can live until they're 76, but as I mentioned, a minority will have a lot more troubles along the way. But as you can see, once again, in the 1930s, 40s, these kids were dying because of tetralogy fellow, and now we consider it a moderate complexity lesion. And you might recall that in 2017, Jimmy Kimmel, who's a talk show host, he kind of put it out on the map as well when his son was diagnosed a couple of hours after birth with tetralogy fellow and underwent surgery in childhood. And really the aims of surgery in 2021 really is to have the intracardiac repair as early on as possible and avoiding the BT shunt, actually, because that comes with its own problems, but certainly a lot of the older patients would have had BT shunts prior to complete repair. So I guess the patients that we continue to struggle with and continue to learn a lot about is these patients with cyanotic heart disease, or with complex congenital heart disease. So cyanotic heart disease, the repaired univentricular physiology, the Fontan patients. And so they are definitely the ones that we have a lot to learn from still. And certainly there will be a lot that we're going to learn over the next decade or so. And so I've come kind of to the 1960s, and 1960s was a big time in terms of cardiac surgery, congenital cardiac surgery. So you can see on the left here, this is Rastelli. He performed the Rastelli procedure for transposition with pulmonary stenosis. This is Donald Ross, who does the Ross procedure. It was in the 60s as well with a pulmonary autograft. And this is Mustard, who did the Mustard procedure for transposition. So there was a lot going on at that time, a lot of innovation, a lot of new surgery, and a lot of babies' lives being revolutionized by these procedures. And so when you come to complex congenital heart disease, I think this spectrum right here is it. It is basically when a baby is born, you always want to create a repair where you can create two ventricles. If two ventricles is always better than one, but there's always certain situations where you will only be able to work with one ventricle. So tricuspid atresia, which is hypoplastic right ventricle, you only have one ventricle. Hypoplastic left ventricle, you only have one ventricle. And this is another one, double inlet left ventricle. It's basically where the mitral and tricuspid both feed into one, and the ventricle, and they usually have a hypoplastic ventricle as the other one. And so, they can generally be all clumped together, and the solution or the repair for these procedures is a Fontan procedure because they only have one functioning procedure. And this has revolutionized the lives of these patients, the cyanotic and the univentricular patients. And this is the gentleman who it's named after, Dr. Francis Fontan, who passed away a couple of years ago now. He was a French surgeon. He was working at the University of Bordeaux. He came across his first patient with tricuspid atresia when he was an intern. And he was perplexed because ultimately what happened was that young child with tricuspid atresia died. And at that time, all he could think was, if you only have one ventricle, surely the only way to fix this is to do a heart transplant. But he kept thinking about it. He kept wondering what else could be done. And, I think the great piece about this is it's always the person at the bottom that has the biggest struggle, and everyone kind of just builds on it. And certainly before the Fontan procedure was actually, the Fontan procedure, in 1950s, William Glenn and Jose Patino had already come up with this Cabo pulmonary shunt, which is basically as it is, it's cable flow, so it's either IVC or SVC going to pulmonary artery. And so you can see here what this was done in dogs. So they wrote it up. I think there was about 7 dogs in this. So this was done in dog models. They went ahead and ligated the SVC just above the right atrium. This is the azygos vein. They ligated that too because it drains into the SVC. And then they've disconnected the pulmonary artery. So that's the right pulmonary artery and the left. And so then the SVC is connected to the right pulmonary artery. And the Then this is the right pulmonary artery, the proximal end, left pulmonary artery, and this is the main pulmonary artery. And so what they've basically done is they created SVC to RPA flow. And what they found in the dogs was it was actually tolerated really well. It remained patent. It didn't. The dogs didn't develop collaterals, and there was no oxygenation problems, no desaturation, and so it was fairly successful. And so this was kind of the work that Francis Fontaine was using as he was trying to work out what he could do for patients with tricuspid atresia. And so he kept trying to close the tricuspid valve in these patients, in I shouldn't say in patients, it was in dogs, again, dog models. And what kept happening was the dogs kept dying. So it really wasn't working in the dog models. He never published it. But then late 1960s, he becomes the head of cardiac surgery at the University of Bordeaux. And someone broaches him with a patient with tricuspid atresia. And even though he had been unsuccessful with the dog models, he was confident that this would work in a patient. And as I said, 1960s, anything was possible in terms of congenital cardiac surgery. You had a lot of people, who had done some revolutionary stuff. So I think, as many people who try new things in a different era, there's going to be skepticism, but he went ahead and did it. And so this was the first case. This was this young girl, performed in April 1968. And so the patient had tricuspid atresia. And so what he did was, hypoplastic right ventricle, so just one ventricle that's functioning. He went ahead and did that Cabo pulmonary shunt. So he connected that SVC to the right PA. And then he's connected the proximal end of the right PA to the right atrium. He's tied off the pulmonary artery just above the pulmonary valve, so there's no flow going through that way. And then he's closed off the tricuspid valve because it's not working and the ventricle below it's hypoplastic anyway. And so basically what's happening is all the IVC flow is going all the way directly into the pulmonary arteries. It's going into the left side. And this SVC flow is going all the way into the right pulmonary artery. And this was successful. And so he actually put a valve in here. At that time, they thought you needed a valve conduit. So this is actually a picture of a valve they put in because they thought they would need valve or to allow for movement, allow for forward flow because you don't have that RB contractility to assist with flow. And it was successful. They did, and they found that, the patient's hematocrit decreased. So the secondary erythrocytosis improved. They weren't as cyanotic. The IVC pressures went up a bit to 15, which we would consider kind of the upper limit of normal these days, but it wasn't horrible. And they felt that it was overall a success. And they did 3 cases over the span of about 12 months, I would say. One patient died, but she was a bit older, a bit sicker. They did write these up in 1971. And they felt that it was actually a feasible operation. They said it was not technically difficult. And they waited for at least 30 months after the operation before reporting the technique. The immediate short-term results were good. They did, however, wonder that whether these patients would develop atrial arrhythmias, because if you can, which they were absolutely correct, they can, because if you can imagine that right atrium is now getting all the IVC flow, it can dilate, and it was more predisposed to arrhythmias, atrial arrhythmias, and thrombus, actually. But, since that, multiple other physicians, surgeons have tried to improve upon it. And these are some of the people who have worked upon that procedure. And basically in 1988, they came up with this total cavo-pulmonary connection. They thought that connection that was initially created was probably not ideal. And 53 years later, since that first Fontaine procedure, this is where we're at. So most patients will have a bidirectional glen. It just means SVC is connected to the PA. We do not disconnect the pulmonary arteries anymore. So we just leave the pulmonary artery as it is. It's connected to the RPA, but there will be flow going to the left as well. And then they get the Fontaine tunnel in a staged procedure. And so here is the lateral tunnel extracardiac. they're virtually the same. It's basically here extracardiac, you're seeing it's a Gore-Tex conduit that connects the IVC to the RPA, and so it's providing all the flow. So basically all the caval flow is going straight to the pulmonary arteries, bypassing the heart, because the heart, there is only one ventricle, which becomes the systemic ventricle, and it is connected to the aorta. So this basically revolutionized, young children who were born with single ventricles. They would die. There would be no option for them. But now there was this option of creating a total cavo-pulmonary connection. But it wasn't perfect, and even to this day, it is still considered a palliative procedure. And the reason being that you do not have the contraction of an atria involved in this. You don't have RV contractility to provide forward pulsatile flow. And so it is very much reliant on passive flow. And so what we found is that over time, the Fontan can fail. It tends to be more so as they get into adulthood. It will vary in terms of ages, but generally when they've reached adulthood, they're at risk of valve disease, ventricular dysfunction, arrhythmias, thromboembolism, just by the fact that they have passive flow in that conduit, but also coagulation factors are also abnormal in these patients, so they are slightly more prothrombotic. Fontan-associated liver disease, again, by virtue of that passive flow, and then you can lead to hepatic congestion. Macroscopically and clinically, it presents much the same as any form of chronic liver disease. And then protein-losing enteropathy, that's got a number of proposed hypotheses, some of them related to congestion of those mesenteric vessels, endothelial dysfunction, etc. But as I say, it improves mortality, but it's by no means a cure to this diagnosis. And so the thing with congenital heart disease is it is a lifelong chronic condition, and more so for those moderate and severe or complex congenital heart disease. They may need repeat interventions, arrhythmia, heart failure. They may need lifelong medical therapy at a young age. So these are all things worth discussing. And I think the reality is, while, as I was saying, so it is a lifelong condition. And once the Fontans failed, the only option after that really is heart transplant. If they have concurrent Fontan-associated liver disease, then it would be a heart and liver transplant in a more minority of populations. So I think what we've done is, over time, we've definitely improved the life expectancy of these patients. These patients are living into adults, and there are many, many success stories, but there are also very sad and tragic stories amongst them. But the question is, we've improved their life expectancy or quantity of their life, but have we improved the quality of these children's lives? And I think that's something that's really being studied a lot more recently in the literature. So, quality of life, these are simplistically three things to consider. Physical functioning, what is their physical capacity, mental health, mental wellness, and then overall satisfaction in life. That's a pretty subjective assessment, and that's going to vary between patients. And so this was published just earlier this year, and it was a multi-center study across 15 different high-volume congenital centers, and they looked at these components of quality of life, and what they found was physical components. So these were questionnaires that the patients were given, and what they found was that those with coarctation and isolated aortic valve disease, they reported the best in terms of physical capacity and ability, versus if you have a look at the top cyanotic patients, Eisenmenger, Fontan patients, they reported the most symptoms. But you can see that there's quite a difference between Fontan and cyanotic patients. I will point out, the majority of our Fontan patients are not cyanotic. And so that's why a lot of them will feel quite well. And if they're not in that phase where they're having repeated hospital admissions, they can feel quite well. But certainly once they're cyanotic, it can change how they're feeling. And then you can have a look down here. It varies quite a bit. So a lot of the moderate complexity lesions fall into here. But you can see here that repaired ASD, VSD kind of falls in just below the middle there, which is a little bit unusual because it is a simple defect. There might have been more to these lesions in these cases, but it is just worth noting. They looked at mental health. It was a similar spread. So for anxiety here on the right and depression, you can see that those who did the best were coarctation of the aorta, isolated aortic valve disease, same with anxiety as well as with depression. And those that reported the most anxiety and depression were the cyanotic patients. And it's a similar spread across the others, other diagnoses. And so in the mental component summary, it was a similar distribution. And then in terms of satisfaction with life, same thing, coarctation and isolated aortic valve disease. It's interesting coarctation patients do so well because coarctation is considered moderate complexity, but they within this time frames in between when they do not require intervention, they're actually completely asymptomatic. So I could see why that would be the case. And the cyanotic patients obviously reported the worst in terms of satisfaction with life. And the small ASD and VSDs kind of come in the middle here, which is, again, a little bit odd. But I think what it shows is that a patient's physical capacity really correlates directly with their mental health and mental well-being and overall satisfaction with life. And it may not be just related to the diagnosis or the anatomy underlying it. And so this was from the 2018 ACC/AHA guidelines for adult congenital heart disease. And they kind of came up with this anatomy and physiology classification. And so it's not just about anatomy, but it's also about the physiological state. So physiological state, NYHA class. Do they have arrhythmias? Do they have normal exercise capacity? Do they have extracardiac dysfunction? Like, do they have renal dysfunction related to their cardiac disease? And that's very variable between any one anatomical diagnosis. So again, I'm going to use Tricuspid fellow. One of them could have none of those as a factor, and they could be physiological state A, versus we have a patient who's physiological state D and is nearing transplant. So it can be quite variable, and that's one of the things when you study congenital heart disease in terms of studies and literature, etc. It's quite a heterogeneous population, but it also probably explains why in that middle spectrum where you were seeing small ASD and VSD patients reporting, physical symptoms, it could be because maybe they had some sequelae of the ASD or VSD, but certainly there's arrhythmias, etc., that might have popped up that might affect how they're overall feeling. So I'm coming to the end of my talk, but I just wanted to put in a little plug for this amazing website. It's called CanadianFontan.com, and it was established by one of my colleagues here, Dr. Jasmine Grewal, and it's a fantastic website. There are many out there, but this is actually one of the most comprehensive websites for Fontan patients, and it's pan-Canadian. It involves all the Canadian congenital heart disease centers, and it's a site for both healthcare professionals and patients. And, if you think about it, within BC, we look after the congenital patients within BC, and we have just over 100 Fontan patients. So really, if you think about it, it's not a lot of patients. So having that national experience in terms of these patients and learning more about it. This is a fantastic website. It has some success stories from patients as well that you can read about on this website. And just another little plug for BC Children's Hospital Foundation, all the great work that our pediatric colleagues do. And you can make a donation if you'd like through the foundation. In the interest of time, I will not talk about what the future of congenital heart disease is, but I can tell you that where we're going to make the most advances is in those patients with complex congenital heart disease, understanding why a lot of them, say, have extracardiac disease, but also trying to figure out how we can optimize the Fontan circulation so that they don't run into those extracardiac diseases early on in life. And hopefully we can postpone transplantation in these patients. I think that's my last slide. Did anyone have any comments or questions?
I have a quick question just about congenital heart disease. And I had a patient with a BTT shunt, and they had significant bronchial artery hypertrophy and actually presented with pulmonary hemorrhage. I think they had a long-standing history of that, and something might have happened with the shunt's patency. But just for congenital heart disease and tendency for bronchial artery hypertrophy, what's the pathway, or how does that occur, or should it occur?
Yeah, so that's why we've moved away from doing BTT shunts, and certainly any of the patients that have any of these systemic to pulmonary shunts as an adult, they would have developed pulmonary hypertension. So if it had become, it depends on whether so it would have been a good thing if it had become occluded, because then they wouldn't have developed pulmonary hypertension, but I suspect they relied on that BT shunt. So there's not much that can, so it is what we would expect, and unfortunately there isn't a lot about it that you can do. So once they get to that stage, there's not a lot you can do, and there's not much benefit from taking down the shunt either, because if they have it, they probably needed it and they're reliant on it for pulmonary blood flow. Yeah.
So I have a question. It's Barry Casson. Thank you for the talk. What kind of relationship does this program have with the children's, and when deciding on interventions, are there specific surgeons that are trained in congenital heart disease and other cardiac surgeons that know, or is this available to all cardiac surgeons?
So in general, and in BC, as well as other sites that I've worked at, the adult congenital surgeon is usually a pediatric cardiac surgeon. And so it would generally be the same surgeon that would operate at the children's that would operate at the adult hospital as well. So it is a specifically trained surgeon that does these surgeries.
Gnalini, I think that was a fantastic talk. And it's always fascinating to see those people and to realize how recent all these advances have been. You know, I've personally, met and had dinner with Fontaine and Mark de Lavelle and Donald Ross and many of the other surgeons. And, it's all very recent. But things are going on. I did want to say something about the patient with the BT shunt. There are some things we can do with the BT shunt. Sometimes we have actually tried to decrease the blood flow in the BT shunts with devices, and Ron Carreri does that. Occasionally, we have put, depending on the bronchial arteries, sometimes we have put coils into them. So there are occasionally things that can be done, but usually the problem is you've got unilateral pulmonary hypertension, and in the long run, the outlook is poor. Even though there are some things you can do in the short term with these patients. Definitely, patients with BT shunt should be seen in the congenital heart clinic.
Very much, everybody. Who's the moderator?
I'm gonna.
So on behalf of the department, I'd like to thank you very much for the presentations today. It's not only inspiring to see, as Martha pointed out, people that have developed the surgery, but also to see the successes and the fact that our group's continuing to work in this area. Thank you very much.
Thank you.